Okay, well, I had to rush off to get the plane to Newcastle, and I've just come back, and this is the day before I meant to give a presentation, and I don't think this will be it. But if things go wrong, this is what it is, and it's following last week's talk on perio. And so what I'm saying is that within the website that I've made for carers, and that I'm going to update with your help, I'll get rid of a lot of this. Actually, if you have a quick look on there, it's got carers course and quiz. So and below it are mouth health videos. The mouth health videos I think are about 20 minutes long. And when I went to a care home, they said, well, we haven't got 20 minutes. So the 6 I reduced to 5 minutes. And then one of the people I recommend highly, I found out that she'd made 3 different videos using a company that make I think gels and moisture gels, but very useful for people with dry mouth. So anyway, so then I changed it and put them in. And this is it, is that if you've got something better, I can, I'm not proud, I'll stick it in. But anyway, this is, I thought, as background to, I was a dentist, and some interesting about me, this is what this part's about. So on that you could find my innovation, and so you would say that's what it was. It was to put Silver Diamine Fluoride at the gum margin. So when I went on the innovation challenge, the care home innovation challenge, I realised actually, this a little bit like the dentures, people need to have their mouth scanned before they get too frail, and we can always do something, with that. So there's a video explaining how it works, a video that I made as a video short, as you can see there. I'm not sure if I think that was the video short's about, not losing your dentures. And so there's evidence. I asked Storm, which is from Harvard, because that has less hallucinations. So if you go onto that and just type in anything you want, it has to be under 20 words, and as you can see there, it doesn't get it all in, but basically I'm saying what's the evidence for SDF on perio disease. I think there's one study ongoing, one complete saying, oh, it looks promising. The reason nobody does it is there's no money in it, in that the patent's gone. And I think as a university, if you've got a big company and you do some research and say, actually, do you know that mouthwash you've been selling for the last 50 years and you use it on your toothpaste? Well, it's not really any better, than nothing at all. So, you could get into trouble for that. And that's why you wouldn't do the research. So it's similar. I've decided to do a different video. It's similar for the story on why dentists don't promote SDF. Anyway, so I also made a website during COVID, and I gave a talk on prevention, and it's in there somewhere under FD talk. I think it's 3 hours long. It's the only Zoom talk I ever gave. So I'll hopefully do one tomorrow. 20 minutes is the optimum length. Anyway, so these are slides from my dental history as such. And so if you go into it, there's about 3 different videos in an innovation, and I think I made them all about 20 minutes long. But this one is a good introduction to who I am and why I do what I do. And so on it is where the first practice I worked at, and I just put something to say. I didn't have any supervision. When I took the job, they said, we've opened a satellite practice and you'll be mad busy. Well, I wasn't mad busy, and so they weren't mad busy either. So they stayed in the main practice, and I more or less worked on my own with a trainee nurse, meaning, well, she'd never done the job before. So that was quite a baptism of fire when you look back. And you have to be quite resilient for that kind of stuff. So I did get some support, but it was always kind of as in an emergency. And so it was the worst start you could possibly have to your practicing career. And even I got a bit depressed. So it's why I became a trainer. I was a dental trainer for 20 years because I had such an awful start to work, and I really wanted to give it up. And I would have given it up if I hadn't got to so much student debt. And when I say student debt, I'm talking about, £2,000, I suppose, which then was quite a lot of money. It wasn't that much money compared to what you get now. And so that's a different theme. But the thing that really made me give up working there, only lasted 8 months, I had to do a GA session. So I saw about, I don't know, 12, 14 children in under 2 hours taking out teeth, while there was an old boy who was a consultant anaesthetist. But the children they weren't really asleep. It was just horrific, and I'll never forget that day. And I vowed never to ever do that again. I mean, you did have to take out children's teeth, but I never did a GA session again. And we stopped them in the end, not because they were dangerous, just because the government twigged we'd stop if we didn't get paid for them. That's how it works. So this is, I was going to talk about perio, because that was the talk we did last week, and the guy talking about statins in the pocket. Well, I did this. This is back then in the next practice I worked at was in Bedminster in Bristol. And again, I got a job there. And then when I started, there were 3 other surgeries there, but the main dentist wasn't there. And we just didn't have much to do with one another. So I had no supervision there either. So we ended up doing something like, I did a few apicectomies there, and they went fine. But I kind of did them from a book. And because I'd seen one, but I was about 8 deep, looking over someone's shoulder in the clinic in 1981. So that wasn't a big help. Anyway, I used the book, and to all intents and purposes, they worked. And you put amalgam down at the end. You don't do that anymore. But they worked well. It didn't look great on X-rays sometimes. But the thing I did do for perio was I made, like you would say, a perio pill that you'd stick down the pocket. So later on, we had all these different kinds of gels that you'd squirt down the pocket to try and change the biofilm, I suppose you'd call it now. But what I used to do was to get some metronidazole and chop them up into a powder, and then mix with acrylic and make little acrylic rods and stick them down the pockets, because that was the idea at the time. And I can't remember if they worked or not, but it was a lot better than doing simple gingivectomies, which is what I used to do. Anyway, so when we were working at the practice, I did some work for a patient, and she was really pleased with it. So, Tony, I'm really pleased with what you've done for me. She said, but the practice is a dump, when you come up the stairs, it's all dirty, and the fish and chip packets on the side. The neck curtains are ripped, and a few of the chairs in the reception area are broken. And she was right. And I said, well, I know, you're right, why don't you complain? I said, because we've been asking the boss if we can come in and paint, if he just pay for the paint. And he said, no, we couldn't come in and tidy the place up. Please complain. And so she did. She wrote it in a letter, and that got escalated from the local area to our GDC. So I had a day in court with the GDC, and I said, look, there's no, the problem isn't, I didn't write the letter. There's no nothing about the work. She was pleased with the work. There's no problems about cross-infection control. It was just that the practice was a bit grubby. And they said, well, you shouldn't be working in a grubby practice. And they fined me the same amount as they fined the boss. Anyway, the boss wasn't happy, of course. And so we parted company. And then a little bit after this, I think this says I can't remember the year now. It might have been 1996. That's how good my memory is. But they brought in a specialist register. I think, that's a good thing. Well, it might have been a good thing for the specialists, but it didn't work out for the general public. And, some things happen, and the consequences aren't great. If you're going to raise the bar, you have to bring in funding as well, and the expectation. Anyway, so we're talking about the next practice I went to was a private practice, and this was, I haven't really got a story about perio there, but what we did have around then was something called HIV. Nobody knew what it was. It had I think, and there's a very famous advert, which I think the videos show. They're all about 20 minutes long. The last one I showed you, actually, for some reason, I didn't add the video, but it plays the first real AI video that I made. On that previous video, I only put in one picture. I just made the text. So you put in the text, and I also made it in English as well. So I think it says it's in Spanish and English, because I was worried about getting struck off. So we ended up having to wear gloves. Well, the interesting thing about HIV was you knew its mode of transmission, and you're there thinking, well, if there's any blood about, whatever, if you've got a cut, you're in trouble. So people forget that the surgeons back then, they used to wear golf gloves because they knew latex, that's not going to stop a needle, it's not going to stop a drill going through, it's that kind of thing. So bringing in gloves didn't really make a big difference. As we know, no one ever caught HIV from the dentist, although that was the scaremongering which put people off who didn't want to come anyway. But what it did do is it did improve standards of cross-infection control, which was a good thing. So let's not knock that. But sometimes kind of politics gets in the way, and that's what I was trying to say. It was the politicians drove it, and then they said, right, well, we'll help get you all have sterilisers. So there's funding for that. But really, it should have happened anyway. And then later on, when it come to endodontics, which I won't talk about, and we all ended up having dishwashers. Well, that was just nuts. But the one good thing, and I only worked here for a year because actually in this private practice, I wasn't busy, and I was trying to do work on the health service, and it just wasn't quite right. But the guy was brilliant. He was the chairman of Pankey. He doesn't know he's the person that I regard as my mentor, because some of the things he said to me, I thought, I don't believe that. And he ran the dental lab that the teaching hospital used, and I wasn't that confident on the work I was doing. So I used to spend some time in the lab and look at the work that was carried out. And then you realise what people actually teach you and say they do often has no resemblance to what they actually do. And their clinical skills are often not that great, which is why many are in the hospital. Anyway, I then went to another practice, which I brought in as a partner. And I was getting old by then. I think I was I must have been about 26. And anyway, so partner in the practice. And these are some x-rays of a patient that I saw. So I can't remember what I was talking about there, but it may well have been that the chap who I say was like a mentor, so he's not here to listen, so his name was Pete Bishop. He was the best clinician I've ever seen. Oh, apart from one guy that I trained, well, maybe two guys I've trained. But I went up to him one day and said, there's a patient with a sinus. I'm going to have to take out the tooth. And he said, is it bothering them? I said, well, no. He said, well, why do you take it out? And I said, well, there's all these courses that I've been told at dental school. He said, well, I'm afraid what you learnt at dental school, a lot of what they teach isn't that great. Why don't you, if the patient doesn't want to have it out, leave it and see what happens. So this particular patient followed me to Stockwood. So those x-rays were, they're 40 years old, 30 years old. They're old. So yeah, would you do the same with periodontal sinus? Well, it depends how much discomfort the patient's getting. It's because, if you take out the tooth and they have the space, and then you start saying, well, you need this and you need that. They might have prepared just to have that sinus that occasionally flared up and they just burst it. You obviously review x-rays. Not that bad. Anyway, so when I was in this particular practice, I bought a Cavimed, and somewhere I've got a picture of one, but basically it's an ultrasonic. It had a sort of second head with a reservoir, and you'd squirt a certain solution into the pocket, because we all thought that chlorhexidine was the best thing since sliced bread. So any problems with your gums, chlorhexidine would sort it out. And it's really depressing, but a year ago I went into a practice where we had a dentist from a different country working as a hygienist, and I said, how are you getting on? He said, it's brilliant. He says, I use this solution, it stops all the bleeding. It's called, and he said what it was, and you think, you know what, this is just nuts. I said, do you get a bit of staining? Oh yeah. He said, well, the other thing you didn't realise is that if you use it at the same time as you clean your teeth, it deactivates the mouthwash, but at least you don't get the staining. And if you brush them, if you use an electric brush and the mouthwash at the same time, you probably improve the gum health from the brush for 2 minutes, and that's a different story again. And so I had the idea then that if you oxygenate the pocket, then that might make the gum health a lot better. And I had this idea, and I had an ozone machine. Now, the reason I had an ozone machine was because one of my patients had been talking about it, how they used it in water treatments to get rid of to sterilize or disinfect, probably more appropriate. But basically, that they used a lot of ozone. Why didn't I use it on teeth? Because it would disinfect any bacteria and viruses in the mouth, But as it is, it was slightly toxic or dangerous. And they brought out a product which was called Heal Ozone, and I've still got it in my garage now. And it was a great product in that it created a seal around the tooth, and you applied the ozone gas. So I went to see the professor and say, look, I think if we use a suck down splint, that could work. And so we started talking about that. The previous x-ray is a woman who had made a video, and it must be it's obviously over 15 years ago. I remember going on the video saying, gosh, she talks absolute garbage. So which is what you might be thinking now. But anyway, so I thought you could adapt a suck down splint. Very much like I've said now that you can make a reservoir for the SDF. But the idea then was to, get the suck down splint using the technology. The person who had told me, his name was Gary, about using the ozone, when they brought out the machine, he took me to the show, the demonstration. I chatted to the clinician, and he started pulling the machine apart, which is a bit unusual. And he says, yeah, it does exactly what he says. He says it's a great product. So I bought it on the basis of him. The research they were doing and the subsequent research, a lot of it you're thinking, well, that's just rubbish. That's not research. Anyway, so I got that, and I wouldn't say it was a moneymaker thing, because I don't think I ever charged anyone for it. And it was really good at getting rid of cold sores. Any patient of mine, they just put the ozone on the cold sore, and it stopped them 90% of the time in one go. Sometimes you needed a second hit, and they never come back. Can't explain why. So that was the hypochlorite. Sorry, I put that wrong. So it's hypochlorous acid that you get. So when I did root fillings, I'd use hypochlorite, then hypochlorous, just to flush it out. And they work great, compared to back in the day. But the other thing I asked him, oh yeah, that's why I wrote hypochlorite. So I said so I had hypochlorous acid, and so I said, well, I've got this, I'm using Sterilux now because, as you know, because of Legionnaires, and use it to disinfect the water lines. If I'm squirting it down through my ultrasonic, what concentration can I use, and do you think it will work any better? And the outcome was, well, I don't know, he said. I said, well, how about if I put hypochlorite down through my ultrasonic? He said, well, I don't know. And I said, well, if you used hypochlorite as a mouthwash, what concentration would you use? Because, clearly it disinfects. He says, well, I don't know. And I said, surely someone's done some research on it. And he said, well, no one's done any research on hypochlorite. And at that time they hadn't. But if you go on to, you go on to the Storm, or if you go on to Cochrane reviews, and look now, there are studies using hypochlorite rinse. One of them was from India, but one of them was from the States. I think it was San Diego University, and obviously use it on students. Probably just get some money for the students. God knows that they need it with the debt they're going to get. Anyway, so the next thing was, this is just about in general. So the person that I showed those x-rays of, I'm sure this is the same person. One of the teeth ended up with a vertical fracture, and she didn't have any, she was exempt from charges. So I made a temporary bridge using my scanning, and that's my scan. You can see it's not full mouth. We used to have to put a powder on it, and my scanner cost a fortune. It costs 10 times as much as what you can get them for now, and the ones you can get now are a lot better, and you don't need a powder. So anyway, this is what I did, and when I finished work, she still had the bridge that I made using a Lava Ultimate Crown. And that was the thing. I come to the States to learn more about this technique, and because the way that you make a crown now is, and I was thinking, we don't need to make a traditional crown. Surely with all the adhesives, we just glue bits on when there's diseased tissue. And ultimately, that's what I ended up doing. So that was my kind of hobby until I gave up prematurely, really. And the reason, so you couldn't get the material that I wanted. And the reason was we found out that basically the American dentists, some of them were cementing them in incorrectly. They were cementing them like you would do for the I can't try to remember the name of the crowns. Right, so it's so long since I worked, I've forgotten the name of the crowns, but zirconia, like zirconia. So they were putting them in like a zirconia or a Emax, when actually they should be using, it was a different type of material. It's a hybrid material. And one of the things I like about the hybrid material, it's a bit soft. It's almost like the same strength as your actual tooth, because zirconia and the Emax, they're harder. So what you'll find is, as we do find, is that the natural teeth wear and the zirconia doesn't, and you end up looks a bit queer, odd, whatever. Anyway, talking about odd, queer, this is what I'm after, is that you hopefully will have taken some photos of before you applied Silver Diamine Fluoride, as someone did here. And what you do is you take a photo before, and then, this person was lucky that they had SDF, because restoring them is a nightmare. The best thing I could use at the time was what I call Fuji Triage, or I think it's called Fuji 7. Anyway, that's what I used, because I've never used SDF on a patient. I acquired it just as I'd had enough and left. And but if you look at the gingiva, now that looks pink and healthy. Now, and I'm betting that this person, it's not just abrasion cavities, and they've been really good at cleaning their teeth. There's something else going on. There are better pictures. But if you've got before and after for showing SDF working for self-apical caries, it'd be interesting to see them, to see what the gingiva's like. So I have seen them. And you think, well, we know that Big Pharma aren't going to do the research, because why would they promote a product that that didn't really make them money? Similarly, if you say, I don't know, you're a dentist and you just come out of college and you had, I think I heard in the States it was $600,000 worth of debt, and someone come in and you said, oh, they got a bit of treatment that needs doing there, and it's going to cost you, $5,000. Or actually you could just see, well, I could just put this varnish on, it'll take me a minute, and that'll cost you $6,000 or $60. But you can see there's a conflict of interest from all sides there. But it's really useful if we could just get it started in care homes in the UK. Anyway, so this is the second part. I don't know how long that is. I was trying to do it for 20 minutes. Anyway, you could get CPD for this if you're interested. If anyone's interested, I'll make up a quiz.